A quick introduction for Dr. Richard Payne. Richard is the John B. Francis Chair in Bioethics at the Center. He was newly appointed in January of this year, and during our strategic planning retreat, he made a presentation. We were kind of launching into the world of genetics and life sciences as a new strategic initiative, and Richard kind of brought us back down to earth in terms of our kind of razzle-dazzle thinking we were doing, and really kind of came back to us and said we really need to focus on the efforts that we're about to embark on and their impact to individual patients and families, and kind of reminding us of our roots, which is basically how it is that we make a difference in the lives of patients and families who are interfacing or intersecting with difficult decisions in their lives as they make decisions regarding their care plans and their life decisions. Richard is also the Esther Cauliflower Chair in Divinity and Medicine at Duke University, and is a world-renowned Payne scholar, as well as, I think we're about ready to go, so Dr. Payne.
So as John said, I wear two hats. I am newly appointed John B. Francis Chair here at the Center for Practical Bioethics, and also Professor of Medicine and Divinity at Duke. I feel a little bit like I'm in the lion's den here, Dookie in the land of Jayhawks, but it's all good, all healthy competition. So thank you for coming to our conference today that we have titled Ethical Frontiers in the Brave New World of Genomics and Learning Health Systems. This is actually really truly a remarkable time in healthcare, as I'm sure you are all aware of. We're now, of course, in the beginning of what everyone acknowledges is a rocky implementation of the Affordable Care Act, which, however, gets us closer to universal health coverage than we have ever been in the U.S. And, of course, there are many features of the Affordable Care Act which has provisions that start to get at serious measures to improve the quality of the way in which we deliver health care. And, of course, scientific discovery marches on inexorably, nowhere more so than in the field of molecular biology and genomics, which is, of course, the scientific discipline that applies DNA sequencing methods and bioinformatics to analyze the function and structure of the genome, the complex set of DNA within an organism. Now, bioethics has an important voice in both healthcare reform and medical research. The promise of genomic medicine does raise many ethical concerns. I'll just list a few. How is the privacy of our most personal information going to be protected? What rules or guidelines will be used to determine how much information is provided to not only to patients but to third parties? What happens when significant genetic information is uncovered that is incidental to the original purposes of the genomic test, genetic test? How do we handle that? How do we think about it? What are our ethical duties and responsibilities? And if I might just ask the remote sites just to mute your mics, that would be helpful. I also, with respect to healthcare reform, we also have, ethics is and should play a big role. In particular, there are many of us, and us being a large us here, being providers, payers, consumers, who feel that we actually have a moral obligation to improve and transform our current system so that it provides consistently higher quality at a fiscally sustainable level. There is a great need to transform our current system from this loosely coordinated care with variable quality and often high cost into a system which provides more continuous care at higher quality and which is continuously learning and which is which is a continuous learning and hopefully even a quality improvement kind of machine in operation. And the question this raises is, do we need modification in our current ethical oversight and regulatory structures to facilitate the progress of transformation of our current system into a more continuous, high-quality learning system? In particular, as these activities will necessarily blur the distinctions between what we have traditionally called research and routine patient care. And should we be thinking about or looking at how we modify our oversight structures for research and even clinical care to accommodate what hopefully will be a new norm? So this brings up a number of questions that we will address today in this conference. How are patients and families being informed about the application of these genome sequencing in both research and clinical settings? What are the obligations of patients and providers to participate in the kinds of activities in both research, particularly as we continuously blur distinctions between research and routine patient care that is important for continuous quality improvement? And what ethical frameworks and oversight structures are important to, on the one hand, protect vulnerable patients, and yet, on the other hand, not produce unnecessary burdens or barriers to the outcome studies and comparative effectiveness research that are so important to creating higher quality health systems. So to address all of these kinds of questions, we have an outstanding group of local and national speakers who have expertise in the area of genomics, clinical medicine, outcomes research, translational research, bioethics, and implementation science. Now, we've organized the conference so that we will have these experts, speakers, give relatively brief talks, and we'll engage them in a panel discussion and engage you as the audience and engage our remote sites in a dialogue and in questions and answers with speakers. So we're looking forward to an exciting day to address these very, very interesting questions. And there's no better person to start us off than Dr. Stephen Kingsmore, who is the director of the Center for Pediatric Genomic Medicine at Children's Mercy Hospital. Dr. Kingsmore is a nationally and internationally known scientist. And the work that that he's doing here is just amazing. I understand that with a single drop of blood, Stephen and his staff can produce a genetic test that scans for 600 severe genetic childhood diseases and provides results in not months and months, but in 4 to 6 weeks, that ultimately determines the cause of the illness and the most effective treatment for children, for that child. This technology was actually named as one of Time Magazine's top 10 medical breakthroughs in 2012. So without further ado, I'd ask Dr. Kingsmore to come and tell us about his work and the state of the science of genomic medicine. Stephen?
Good morning, everybody. Good afternoon, maybe. Apologies. You know, we're in Kansas, and my laptop is from Missouri. And I just didn't like the crossing the border at all, so sorry about that. This has been quite a crazy 24 hours, so let me just give you a very brief recap. So yesterday afternoon, I visited with our institutional review board because they had privacy concerns and consent concerns about our protocol, our repository. It was my 26th wedding anniversary, so I stayed up way too late. I then ran into a 3-lane traffic accident on I-35 North, and then my laptop won't work. So it's good to be here, notwithstanding. Now, I'd like to say hello to the folks at Duke because I spent 6 years there. So hi, Dukies, and hello to you in Missouri. And let's get started. I am not going to get into ethics so much today, okay? I'm going to set the backdrop here in terms of what is it we're doing and what is creating these issues. So a couple of disclosures to start off with. I'm heavily influenced by the manifesto, which is contained in Matthew 5 through 7. It colors pretty much everything I'll talk about. What I will show you has received substantial in-kind support from a company called Illumina, who make sequencing technologies, and I sometimes get paid for talks. I don't believe I'm getting paid for today's. No? Good, so that's not a disclosure. All right, now, the problem that we have here is I got all kinds of really cool video clips, and we're just going to see if they work. Now, they may not, because the reason I have this really fancy laptop is it's got a very fast video card, but we're going to see. So what we're talking about here in terms of my work are monogenic diseases. So you know that genetic diseases fall loosely into two categories. There's ones where a single mutation or pair of mutations in a single gene, single place in the genome, is necessary and sufficient to cause a disease. And the prototypic disease is sickle cell disease. Here we have the initiation codon, the actual code of the DNA, 3, 6, 9, 12 letters. And each 3 letters of DNA, it's a 4-letter code, A, C, G, and T. They encode this initiation methionine, and so on as we go down here. The start of the protein sequence of hemoglobin beta, which is a major constituent of red blood cells. And if we change a single letter, an adenine to a thymidine in the 6th codon, the 6th triplet, it changes a glutamic acid to a valine at this corresponding amino acid position, and that in situations of low oxygen tension causes the sickle cell to change from a donut morphology to a sickle morphology. This disease affects 300,000 newborns per year. It's the commonest genetic disease. So that's what I'm talking about here. These are deterministic diseases. And unfortunately for the public, they view the genome largely in that light. Partly it's our own fault. We have somewhat taught them that. And so they think as we decode an entire individual's genome, that everything in the genome is deterministic. You know, I have a risk factor for prostate cancer. I really ought to have my prostate gland removed. So there are these diseases called monogenic diseases where they are deterministic. But the vast majority of the genome and the variation therein afford a certain level of risk or susceptibility to a condition or a trait. They're not deterministic at all. So anyway, let's get back to the talk. So I told you I was going to focus on these childhood diseases. There's about 7,500 of them, and we know the molecular basis, we know the place in the genome, the affected protein and gene for about 1/2 of those. As of a couple of weeks ago, it was 3928 diseases that, because we know where it is in the genome, we can scan a genome and diagnose a child with that condition, diagnose their parents as carriers of that, and give them information about recurrence risk. If you add all the diseases together, they're pretty common, a lot more common than we think, because they're called orphan or rare diseases, and they are responsible for 17% of admissions to Children's Mercy Hospital, and about 1 in 5 infant deaths. They're the leading cause for admission in our Level 4 neonatal intensive care unit. So today, the norm for diagnosis of these conditions is clinical diagnosis. We have very expert geneticists who can look at a dysmorphic child and say it's condition A. However, there are very few of them. It requires decades of experience, and they can't cover the panoply of diseases. And so what we want to do is to take this and do, as the guy who introduced me said, be able to decode the genome in a matter of hours or days and give a rapid diagnosis that allows us then to give specific treatments. If we have a molecular diagnosis, we can give a molecular treatment. If we have a clinical diagnosis, we're really limited largely to symptomatic treatments. So genomic medicine is a buzzword. Really all that it means is using genome information to guide medical practice. And our focus is on doing that in newborns and children. So I'm going to talk very briefly about 3 types of tests. The first one's called tag scan. This is that test that scans for 750 diseases, 514 genes. This is a routine billable test that's available to our physicians, probably to physicians here too. Whole exome sequencing, which many centers around the country are now doing. This is a research tool, which then is followed up by a confirmatory test to make it a clinical test. And there we are surveying the 2% of the genome, which is all of the genes. So theoretically, it should give us access to all 3,928 Mendelian disorders, theoretically. And then lastly, our specialty is to decode the entire genome in a process that we've shortened to 1 day. It's kind of expensive. We do that in our neonatal intensive care unit so that we can give almost immediate diagnostic information for acutely ill babies. I think I just said all of that. So as you think about genomic testing, there are different flavors. That's my point. And the consent, the privacy issues, the extent of genomic information that's provided is really incredibly different. This panel test, tag scan, really is only looking at childhood diseases. It's not looking at BRCA1, an adult onset condition with a high likelihood of developing breast cancer, the reason why Angelina Jolie had bilateral mastectomy, in addition to her having a very strong family history of breast cancer. So that's not on our panel. And ethicists are wrestling a little bit these days with what's called the incidentalome, which is when you decode a genome, you're looking for something, but you find incidental things you weren't looking for, such as a BRCA1 variant. And what do you do with that? Do you have a moral imperative to share that with the parents of a 3-day-old baby? That's a very difficult question. Could that prejudice their care of the baby? You know, should that information be reserved until adulthood? What do we do with this? What about a carrier status, where in fact the baby is not going to be affected by a disease, but that carrier status came from one of the parents? Do we need to tell a parent to go have their genome sequenced at that region to see if they are indeed at risk of having another affected child? It could influence their reproductive decisions. And then we find other stuff like dad wasn't dad. So how do we deal with all of this? And that's why today's dialogue is so pertinent and relevant. So some of the testing does not have a lot of these issues, okay? That's my point here. So we're going to start into some stories, and hopefully our videos will work, and if not, that's okay. I might try and just mime them or something. So this is a baby who was born a couple of months ago, child 487 in our program. This baby, I'm going to speed up a little bit and see if we can get us back on time. Oh, there's a clock up there. Great. Okay, super. So this is a... Sorry? This is a baby who we knew was going to be ill. And so we have a fetal health center. This is another issue ethically. So we actually are providing medicine for fetuses these days. The fetus does not have a legal standing today, really. How come we can treat them? How come you can be the physician of a fetus? Interesting concept. Okay, so anyway, this baby was being seen in our fetal health center and had an MRI and had several structural defects. Was then delivered because of this in the fetal maternal health center. So the concept there is, if you know that the baby's going to be sick at birth and will require corrective surgery, have them born in a children's hospital with the surgeons on call, the operating room teed up. So the baby was born such, was admitted to the NICU to have repair of the omphalocele, which basically means that the covering over the gut hadn't formed, okay? So basically the intestines were visible. This baby did okay in the NICU. Basically generally the treatment is to let this thing gradually heal, so the baby was undergoing that, and then developed acute liver failure, which was surprising. The baby had had an extensive workup, and then my team was called in. The baby was enrolled in the study, and as is typically the case, an extensive workup and no diagnosis when we are called in. So we have this process that allows us to make a genomic diagnosis in 24 hours. So we obtain consent from the parents. A lot of issues around consent. Their baby has a mystery disease from which the baby is dying. We can enroll you in a research protocol that could give you an answer. Is that really consent? It's difficult, isn't it? What if they say no? You know, we don't want to do research, we'd like to test. But the test isn't available except in a research protocol. Anyway, so we get consent, we get a DNA sample from the baby and the parents, and then very importantly, I'm going to get into this in a second, we enter the clinical features. In this case, it was liver failure, the omphalocele, and some other structural abnormalities into a software system. Okay, I'm just going to talk a little bit about the genome. The genome is absolutely beautiful. It's fascinated me most of my adult life. It's also fascinating my computer. You know, yet again here, I think the issue is that we're in Kansas. Here we go. So, if you took a piece of paper and you covered it with DNA letters, that's A's, C's, G's, and T's, how big would a genome be? We're good, buddy. It would be a stack of paper 300 feet high. So when we decode a genome, we are decoding a book that has how many pages it takes to be 300 feet high. So as you can imagine, this is computationally quite a difficult exercise. Okay, now then, the wonders of modern science. So one issue that we have is we are looking for over 4,000 diseases. Thank you. How does a physician know which diseases to test for? Now, most centers in the United States who are doing this are scanning the genome and then sort of manually correlating the genome with what's going on in the baby. Now, there's an issue with that. There's several issues. First of all, a genome is a very big place, so it takes often weeks or months to sift through the information. Second of all, the body of knowledge in terms of 7,000 diseases is not something that's readily accessible for physicians. And then last of all, you're going to stumble upon incidental findings that I talked about. So to get around that, we developed a very simple thing, which was you just click on buttons to bring up the baby's disease. And so here is what our baby had. It had prolonged APTT, prothrombin time, thrombocytopenia, omphalocele, elevated alpha-fetoprotein, mild fetal pyelactasis on MRI, and most pertinently, liver failure in infancy. It was not fatal, but it was headed in that direction. What the software does is then to match that to all of the diseases that are relevant to that child's illness. Isn't that cool? So what that allows us to do essentially is to remove the incidentalome. These are what are on target in the genome for that child. So that's kind of a neat way that we've gotten around this huge controversy over what do you do with incidental findings. We don't see them. They're in the computer. They don't pop out. It also gives us a rank-ordered list to search through for what's going on in the child, and that allows us typically to interpret a genome if it matches one of these diseases in 5 minutes or less. So, we now know that there are 254 diseases in that child's genome that we should search for. So the next step then is to take the DNA and decode it. And I'm not going to get into that, but we have several ways of doing that. There are several stages. Our sequencers generate very short fragments of DNA sequence. The entire book is 300 feet high. We generate it 100 letters at a time. And so our computer algorithms take that single 100 letter fragment and search around the 300-foot-high book to find its matching spot. As you can imagine, it occasionally makes mistakes because there may be some repetitiveness in that 100-letter code. So this is an issue for us, and it can give false positives. So there are other concerns in terms of the quality of the data, which bear upon the privacy issues, the consent issues, and very importantly, the delivery of information. Key bottleneck here is we have a medical community, a nursing community, a health provider community who didn't get taught about genomes, and most of whom might have some concept, but not a deep knowledge. And so how do they both order testing, understand what they're asking for, and then very importantly, how do they convey that information back to the parents of an acutely ill child? Okay, so we've got the sequences, billions of these 100-letter fragments. We then have to find the place in the genome that they match. And having done that, we need then to see if there are any letter changes. And what I'm showing here, so these are the very short sequences here. They've been matched to the genome. So this is the reference genome here. You can't see it, but these are A's, C's, G's, and T's. This is the protein sequence in below. And these are the individual 100 nucleotide reads. So they are matching. You can see they tile across the genome. We sequence the genome very deep. So we have many, many sequences which we summate to give what we call a genotype. Remember, you're diploid. So you got one genome from mum, one genome from dad. So when we decode a genome, we're actually decoding two genomes. And so at every position, we're looking for two letters. You can be A, it's really AA, AB, or BB. Or in some cases, we don't pick it up. So that's another possibility. So in this case here, I don't know if you can see this, but about half of the short sequences are reading a B and half an A. So this is an AB. So mum's chromosome or dad's had a single letter change at that position, and the other parent did not. Okay? So we do that, and at the end of the day, ignore some of the stuff here. It's part of the thrill of giving a presentation that's an amalgamation of two because we're in Kansas. Does that make sense? Doesn't make sense to me. Anyway, there's 5 million of these. Each of us here in the room has about 5 million letter changes from what we would call normal. Now, there's no such thing as normal. We are all outbred. Actually, human beings are uniquely diverse. I don't know if you know that, because we outbreed, most of us. I'm not going to make any jokes about North Carolina. I think I just did. Sorry about that. So we are at this stage. We have a list of 254 diseases. We have a list of 5 million variants. We have to mix those up. Now, a big part of the equation here is adding information, what we call annotation. And so again, we use our computers to take all 5 million variants and append to that a body of knowledge about that variant. Basically, we can use a bunch of tricks to tell, could that variant cause a disease? Not with precise likelihood, but we can add a likelihood number to it. This definitely causes a disease, such as the glutamic acid to valine change in sickle cell anemia. It's well established in the literature. Or we haven't seen it before, but it's really likely that it kills the protein. Or we haven't seen it before, but it may or may not. Or almost certainly it does not have an effect on the function. So at any rate, we pull all this together. We give it a number score, where number 1 means causes disease, 2 means likely to, 3 means maybe, and 4 means do not. And in this particular child, you can see that there was a category 3 variant which met our symptom list and met our disease list. So our tool that I mentioned earlier on takes all the symptoms, matches all the symptoms to all of the diseases, and matches all the diseases to all of the genes. And so this system pulls that in, and these are the symptoms, These are the diseases, these are the genes. There's 254 diseases, and this is one of them in yellow, hemophagocytic lymphohistiocytosis type 2. And so there is a variant. The child is heterozygous for that variant, and this gives you the timeline of when we got those results. So now we're looking at the variant. Mum, baby, and dad. You can see here why we get immediate, this is an immediate paternity test, right? We're always doing this, looking at the trio. So in this case, we've got a single letter change. Do you see it there? It's a G to an A, which changes this amino acid. It's present in about half of the sequences. Each of these is an individual sequence. This is the reference, the so-called normal human genome, and the protein code. Okay? So about 1/2 of dad's sequences have that change. So dad is heterozygous. One of his 2 chromosomes at that location is affected. The same for baby. So baby inherited that from dad. Mum does not have that. And so the other of the baby's chromosomes has the normal residue. Okay? We got it so far. Dad's unaffected, baby is. So, and this is a gene called perforin 1. When we scanned that gene further, there was a second variant, different position, and here you see it comes from mum. So mum is a carrier for this. Dad is a carrier for this. Different mutations. And tragically, they got married. Not tragically, they got married. Tragically for them, this was hidden in their genome, and their children have a 1 in 4 chance of being affected by this disease, and this baby was affected. So, a lot of stuff going on there, right? So we have an immediate diagnosis. We know what the baby has. Second of all, we know that mum and dad are carriers, so we can counsel them about the risk of recurrence in a future child. That could influence their reproductive decisions. I don't want to have more children. I do want to have more children, and roll the dice. I do want to have more children, but I want some form of testing, maybe amniocentesis. I would like a sperm donor or an egg donor, or I'd like to adopt. A variety of choices that we can counsel them about. In terms of the baby, the story has a happy ending because this diagnosis came with a treatment. That disease, hemophagocytic lymphohistiocytosis, you have to go to medical school to be able to say those words fast. They don't teach you really anything useful in medical school, apart from how to spell and say big words. By the time you get to my age, you can't spell them anymore, but you can still say them. So anyway, we brought this information to the NICU team. They didn't believe us. They did confirmatory testing. Then they believed us. And the result was that we were able to change the baby's treatment, and the baby has recovered and is still actually in hospital as that closure of the skin over the intestines continues. So a beautiful case here of something that was completely impossible a few years ago. The rapidity and the scope of the testing. Okay, one more story. We're going to have to change here. Excuse me a second. Now we're going to really put this little computer through its paces. Second. You are a very forgiving audience. Especially those of you who can't speak, who are online. That. There we go. There we go, it's working. All right, this little dude, as you can see, he's Polynesian. And as you can see, he loves basketball. So he's got something in common with at least 2 of our sites. And this baby was born with acute anemia, profound neonatal anemia. Tragically, his brother had died at 4 days of age of profound anemia. That immediately makes us think of a genetic illness. Onset in childhood, 2 affected siblings, and a very rare disease. He had a really, really rough start to life. He kept getting anemic. He kept requiring blood transfusions. And in fact, this is the lowest hemoglobin I've ever seen. And he came in cardiac arrest. so low was his hemoglobin. So he's now 20 months old. Since it worked, we'll do it again. For 20 months, he's been in and out of hospital, so his quality of life is as you can see, mixed. And for his mum, this is incredibly stressful, and his dad, there's his mum in the background. He had received over $30,000 worth of diagnostic testing without a diagnosis. Now, you can live on blood transfusions, but tragically what happens is you get iron overload, which results in liver failure. And so our little boy here was starting to have liver issues. So he was enrolled. His parents had a lot of concerns. I do have to tell you that often it takes us several meetings with parents. I say us, you got to remember I lead a team, okay? I give talks like this, but they don't let me near patients. Actually, come to think of it, they don't let me near the lab that much either. As you can tell, I'm, I have some issues. Anywho, I got off the track, didn't I? Yes, consent. So often parents have a lot of questions, and as do the physicians, and we have to work through those with the parents, with the physicians. We always use a genetic counselor. These are folk who have received training specifically in how to counsel people about use of genomic information. Clearly that needs to be part of the puzzle. It pretty much always is. It's a guideline that is generally applied, but that's a very important thing here. Without those folks, it would be incredibly difficult to do justice to the information that we're obtaining and then delivering. Okay, let's get back to the child. So very similar picture to the last one. The reference genome, the protein code, it's a different gene. It's called SEC23B. You can see that we have the same type of picture as before. The baby is a carrier. One of two copies of his genome has a C to T change at this position in this gene, and it turns out, I'm not showing it, but he got that from mum. So again, mum is a carrier and has contributed that to her son. Dad, same story, is a carrier for a different mutation in the same gene, and the baby is a compound heterozygote. So both copies of the protein don't work, but for different reasons. Mum and dad are healthy carriers. So the diagnosis, type 2 congenital diserythropoietic anemia, a very rare condition. What we're now getting into, another ethical thing that I'll throw out there, is that many of these conditions do have treatments, but when you've only had maybe 30 people in the world ever have the disease, this is often the case. One person had received a bone marrow transplant which was curative. So this is an experimental therapy, and so increasingly now we are not satisfied with giving a diagnosis. We will mine the literature, we will sit down with the pathologists, the physicians, the genetic counselors, the bone marrow transplant team, the attending physician, a hematologist, and we'll convene this group and we'll say, is there a treatment? What's the risk? There's a rather high risk of bone marrow transplantation because you have to wipe out the resident marrow, ablate it. And so for a period of time you have no bone marrow, and obviously the transplant has to take, and so you basically have no immune function for a period of time. Maybe 10% mortality. So very severe treatment, but potentially curative. We call these N of 1 clinical trials, and they go hand in hand with genomic medicine. They're the fruit of genomic medicine. And for individual families, they offer new hope. Never been done before, hitherto, because we didn't have definitive diagnoses, or because our definitive diagnoses occurred too late for things like this to happen. Remember, I told you that as this disease advances, you develop liver cirrhosis, fibrosis, and then liver failure. In our child, fortunately, he did have minor liver damage. We had to do a liver biopsy. It was not what we call bridging fibrosis. It was reversible. So we started him on iron chelation therapy to get the iron out of his body. Remember that blood, 5 minutes. Blood is really iron in red blood cells. He then went on and got a transplant. He's had some infection problems since, but he's now back home. And pretty good quality of life. He had a really rough series of infections because he was in immune suppression. But another case where there was a cure. Okay, I'm going to skip through a few slides. I will probably go back to my other presentation for the last 2 minutes of the 5 minutes remaining. I'm Irish, and one of the great things about being Irish is that the idea of 5 minutes is not really something that you measure on a clock. You measure it by, that means I got time for one more beer. So I'm going to have one more beer. What about parents, and we go back to them and we say, we now have a definitive diagnosis, but there is no treatment. The power of answers is something that has blown my mind. Now this again is a very, very tricky issue. If you convey the information poorly, then the parents may think, as I told you, that this disease defines their child, and that their child will die, and that this is a death sentence. And they'll be fatalistic, they may blame God, a whole variety of emotions. However, in other cases, they can feel empowered. They can start to plan for the future, they know the prognosis, they know how their life will start to proceed. It may save their marriage. It may prevent them from having catastrophic diagnostic bills. We can put them in touch with support groups, with other mums and dads who have children with the same disorder. We can get them through social work, into special programs in a more expedited manner because we now have a diagnosis. We can preempt complications because we know how the disease will unfold. So the power of answers, but only if it happens in a setting of continuity of care and in a setting where there is attention paid to conveying the information. Sadly, in our experience across 3 years, we've seen both situations. We've seen parents who took their baby out of the hospital to die, and we've seen parents like this one, who you'll hear from in just a second. So, bear up with me. I'd say we're about a third way through this pint of beer here. Where is the sound button? This is the sound button. Okay, so this is the mum. Let me just put you back into the clinical picture. This is the mum of a couple of boys who are affected by a muscle wasting disease, talking to us about how she made the decision to come and ask for an answer, and how initially she didn't want genomic testing, and then after a while she decided she did. It was something that she needed to process. So let's hear from her.
He was born completely floppy, didn't have a lot of the reflexes a lot of other babies have. It's just generalized muscle weakness. They just did everything slower, but because they did eventually hit those milestones, there was no reason to poke and prod on them.
Okay, so that explains her initial thoughts. Now let's pick it up about a year later.
About a year and a half ago, I went to my family doctor and I said, I need to know what this is, what their future holds. I need to know what to tell them, when my son gets in high school and if he wants to play football and he doesn't have the muscle strength or it's not safe. Courtney, when she wanted to have kids, that, hey, is this going to affect your children?
And so she approached us through her physician and requested testing. We ran the test and we made the diagnosis. Again, a rare disease, one for which there is not a treatment, called Nemelin myopathy. And let's hear what Mum said about the day that she got the phone call. All right.
Nemelin myopathy. I will never forget the phone call. The first thing she told me was it's not life-threatening. It changed my life right there, just knowing that they were going to be okay. Ready? Just to watch them run and jump and play, it lets me know that, yeah, even though they might have this disorder, it won't define who they are. You know, they can define who they're going to be, and I think they're going to be awesome. I think they have a huge life ahead of them, all of them.
Actually, a remarkable woman, isn't she? The disease will not define them. What a powerful statement to make. Okay, I need to finish. And I had so much more good stuff to show you. Let me just see, is there anything in here that I do want to show you? So we've had a bunch of cases like this where the paradigm has shifted, where we have dramatically transformed the outlook for patients. This is the child that we talked about, that you just saw. This is a couple of sisters who received a vitamin supplement which could have modified their course. In each case here you see how much had previously been spent on diagnostic testing. So to come to your comment at the outset, you might think genomic medicine is going to be catastrophically expensive and break an already, heavily burdened system. My personal feeling is that when used right, it can have huge, huge cost savings. And remember that these diseases are lifelong diseases, and so the cost of care in these children is often, $250,000 in lifetime cost that we can help change, and certainly get rid of the issues in terms of costs of diagnosis. Okay, critical slide. Am I okay? You're not going to drag me off? Thank you. Okay, this is the inheritance pattern, and this is another really subtle thing. So I showed you a couple of cases where the diseases were autosomal recessive, where both mom and dad were carriers and the baby had 2 mutations and had the illness. So they, as you can see, are the most common type. However, this is something which is happening way, way more than we expected. It's completely transformed our view of genetics, and that is that all of us have new mutations in our genome. They didn't come from mom or dad. They happened at some point between the sperm and the egg being formed, fusing, and resulting in a child. We call those de novo, and they are a frequent cause of genetic diseases. So in these cases, we can reassure the parents that this was a lightning strike, and that while it occurred and it's genetic, the recurrence risk is infinitesimally small. But amazing. And so the other concept that we've had that's been ethically just wrenching for me personally has been the concept of preconception testing. That if it was feasible to do that, we could potentially eliminate genetic disease burden by giving counseling and having people look at their reproductive choices. And certainly in societies with arranged marriages, potentially, like Saudi Arabia, much of the Middle East, you could get rid of these illnesses. And in those countries, there's a much higher risk of these diseases. Anyway, dominant disorders. I think I have one more slide and I'm going to finish. I think I'm just going to finish there. Thank you very much for your attention. This is my team. And that's my funding. Thanks very much.
Dr. Kingsmore won't be available for questions, but I just had a question. I'm going to take the liberty of asking. So if I'm a parent and I say, okay, so what's the chance that you're going to give me information that's either falsely positive or falsely negative? You would say?
Well, yeah, you need to pause and reflect. It's somewhat dependent upon the testing that we're doing. It's somewhat depending on the clinical situation. Mm-hmm. But to give a generic answer, false positives are essentially non-existent. So the assay itself, because we sequence hundreds of times, the error rate on each sequence is appreciable, but not across 100. Okay. And then on top of that, we do confirmatory testing almost always with a different method. So that's beautiful, and something that's very high on our minds. False negatives are actually quite high. Much of the genome is not accessible. Only about 2/3 of the genome can be sequenced with today's technologies, and only about 2/3 of mutations can be picked up in those sequences. And so a negative test result does not mean we have ruled things out. And again, this is something that's very difficult to convey to people because they just assume you scan my genome, my genome's clean.
Thank you. It's beautiful, beautiful work, and sorry that you won't be able to stay with us to answer questions, but we're going to probe some of the ethical issues that Dr. Kingsmore has brought up and others with other panelists later in the day. So thank you, Dr. Kingsmore.